So welcome once again. It's Darina Semyonov here at the Network Management Office of AgeWell. I'm the Knowledge Mobilization Manager here. And today we have both Dr. Thomas Hadjistavropoulos and Dr. Babak Tati talking about using technology to detect pain in older adults with dementia. I'm going to give you just a quick background of AgeWell. I'm sure most of you are familiar with it, but just in case you aren't, and then I'll introduce our presenters. AgeWell partners with 37 universities across Canada. It is Canada's technology and aging network. We have over 150 researchers and close to 400 trainees in our network, as well as close to 200 industry, community, and government partners. AgeWell stands for Aging Gracefully Across Environments Using Technology to Support Wellness, Engagement, and Long Life. Our vision is to harness the potential of technology to provide high quality and sustainable services and solutions to meet the needs of not only the current older adult generation and caregivers as well, but also future generations in Canada and beyond. So this means creating capacity for Canada to further establish its position as a global leader in the field of technology and aging. So our presenters today, our first presenter is Dr. Thomas Hadjistavropoulos. He is professor and the research chair in aging and health at the University of Regina. He is also a registered psychologist and past president of the Canadian Psychological Association. His work has been presented in over 160 peer-reviewed articles and book chapters, as well as 5 published books, including 1 directed to patients. Dr. Babak Tati is a scientist at the Toronto Rehabilitation Institute, which is part of the University Health Network. He also holds an assistant professor appointment in the Department of Computer Science at the University of Toronto, and his research applies computer vision techniques in the development and evaluation of intelligent health monitoring and rehabilitation technologies. And I'm sure you'll hear lots about that today. So take it away, Thomas.
Hi, my name is Thomas Hadjistavropoulos, and you could, I guess a moment ago, do I have control of the slides now? I think I do. I don't. Okay. Okay, I'm good now. So anyhow, this is Thomas. You can see what Babak and I look like with ties. Luckily, you cannot see us now because we're not wearing any ties right now. But we're not at home in our pajamas either. So the truth lies somewhere between the ties and the pajamas. And I'd like to also say that we are not receiving any financial support from commercial entities for this work, although some of the work that we'll discuss today is potentially commercializable, which would represent a conflict of interest that needs to be acknowledged. This is the funding that supports my lab. This particular study or series of studies that we're discussing today are supported by AgeWell as well as by CIHR, the Canadian Institutes of Health Research. And in addition to Babak and myself, co-investigators on this same grant, the CIHR one, was Alex Mihailidis from the University of Toronto, and Ken Prokachin, who is a psychologist at the University of Northern British Columbia. So in the first part of this presentation, I will give you a background on pain in dementia and the problem of pain in dementia and its management, and solutions that we tried to come up with over the years that led to this technology development work, which is the prime focus of this presentation today. And much of the work that I've done over the years involved interactions with many different health professionals, physicians, social workers, nurses, and so on. But I had not really interacted with engineers or computer scientists like I'm doing now. So I had always assumed, all these years of doing this work, that the most important solutions to the problems of Alzheimer's disease would come from medical professionals or from other health professionals. But now I have changed my mind. Certainly many solutions will come from the health professions, but I have come to believe that over the course of our lifetime, the best solutions to the problems of Alzheimer's disease and other dementias will not necessarily come from the medical sciences, but may come from technology development. There are so many things that technology is doing to improve the lives of older adults and others who may have disabilities. Something as simple, I guess, as the Google car, for instance, might solve the problem of many older adults who lose driver's licenses because of visual problems or other limitations. So outlining this presentation, I'll talk about the problems of pain and dementia, some of the laboratory research that led to the developments we're discussing today, and finally our plans toward implementation. And after I talk about the background work, then Babak will take over the presentation, and he will talk about the algorithm development and the technology itself and how that's going to work. So the problem that we're trying to address in long-term care facilities especially is that pain is very prevalent. There are studies that show that older adults in long-term care, as many as 90% of them have a pain problem. But when you compare the older adults with a pain problem and dementia to older adults who don't have dementia and live in the same facility, those who don't have dementia are more likely to be on pain medication despite similar pain diagnosis. Why is that? Well, one reason is that people with severe dementia lose the linguistic and cognitive abilities necessary to report pain, and pain is subjective. I mean, people cannot see if you have a headache or not. Unless they look into your mouth, they're not going to see that you have an abscessed tooth. And you may be suffering in silence. Or you may be manifesting behaviors such as aggression that we often see occur as a result of pain in people with severe dementia. And your aggression may be the result of pain. It's not the result of psychiatric disturbance. And yet we go and give these people who are aggressive due to pain psychotropic medications rather than analgesics. It's really a tragic situation. We know how to assess pain in long-term care. We have developed ways of doing that. Where self-report is absent, there are very good nonverbal behaviors that we can look at that tell us that the person has pain. But when we go to nursing homes and tell them, you know, that's what you can do, they tell us we'd love to do it, but we don't have the resources to do it. So I'll just skip through that slide, basically an outline of what I'm going to talk about. I told you roughly what I'll talk about already. In the initial work we did, and that work started, I guess, over 20 years ago, there was very little known about pain expression in dementia. But there was more known about facial expressions of pain in other populations, normal adults with no diseases or illnesses, but also in another nonverbal population, which was neonates, young infants. There were valid ways of measuring pain in this nonverbal population based on facial responses. Together with colleagues such as Ken Craig from the University of British Columbia, we embarked on an effort to examine carefully the facial responses of pain of individuals with dementia and see if we could use those to better understand the pain experience and to evaluate medications. How do we know that the medication is working if we cannot do a clinical trial? And we cannot do a clinical trial unless we have some kind of an index of pain in this non-self-reporting population. So the facial action coding system is what we use. That was developed by Ekman and Friesen. And that divides your face, the face to 44 groups of muscles. It's a very time-consuming system. In those days, we used VHS video to basically code all these pain responses. And it was taking us about 45 minutes of our time to code about 10 seconds of video. That's to show you how time-consuming it was. But through that research, we identified a number of facial characteristics that, or facial reactions that characterize pain in dementia. Things like lowering of the eyebrows, tightening of the eye orbits, raising of the cheeks. These types of behaviors were far more likely to occur in pain, during pain, than in other emotional states. But as you can imagine, this cumbersome procedure requires special training, and due to its time-consuming nature, could not possibly be used in clinical settings, not realistically, not in a wide scale. So we developed over the years simplified approaches, such as the pain assessment checklist for seniors with limited ability to communicate, or PACS-LAC2. So it's 31 items. And you can see it the way it looks, plus you can see it on the right of the screen enlarged, so you can actually read what the items are. That takes about a couple of minutes to administer. It's very quick. Nurses who have done it a few times can do it in a matter of a couple of minutes. And the PACS-LAC has been shown to be extremely useful when used regularly in long-term care. When we assess pain on a regular basis. I'll tell you some studies of that before we move on to the technology development. One of the first studies we did testing the PACS-LAC involved two groups of nursing staff across several nursing homes, an experimental group of nurses, and those would use the PACS-LAC on all of their patients 3 times a week. It wasn't easy to convince the nurses to do that because nurses are already busy, but they did do it, and they did do it for over 200 days. The other group, the control group, you could say, got the short end of the stick. They still have to fill something out, but not the PACS-LAC. They just had to fill out an irrelevant checklist. That was to control for the possibility that it wasn't the PACS-LAC that was assessing pain, but just the fact that the nurses are attending to the patients. So we compared these groups of patients falling under each nurse over time. And this is what we found with respect to medication use. The blue line are the people who over 200 days got the PACS-LAC assessments, and the dotted red line are the people who didn't. What you see there is the PRN medications. These are medications that are prescribed to be taken on an as-needed basis. So those medications increased over time quite a bit in the PACS-LAC group, but in fact, medication, analgesic medication use was reducing very obviously in the control group. I'm not suggesting that more medication is better necessarily. What we're seeing here is a situation where pain medications were seriously underused in long-term care, and now in this population, they're being used more. When we looked at the pain levels, the blue line are the people who got the PACS-LAC. You could see there was a reduction over time in the patients. But so these are the PACS-LAC scores over time, and that's a significant reduction, a statistically significant reduction. Whereas the scores, the dotted line at the top, these are the people who completed the irrelevant checklist. Those scores on the irrelevant checklist didn't change. But what was rather surprising is that we monitored the stress levels of the nurses. So we know the patient's pain is going up, the medication use is improving. What's happening to the nurses, the busy nurses who are saying, I don't have time for extra stuff because my schedule is already full? Well, in fact, we found that when the nurses fill out the PACS, they report reduced stress and work stress and reduced burnout over time as compared to those in the control group. That's why I always say when I sell these things to nurses, when I try to sell, I use metaphorically because we don't sell the PACS like we give it for free. I tell them, if you guys want to relax, there's nothing more relaxing you could do than sit under a palm tree with a pina colada in one hand, filling out the PACS on the other hand. I didn't do that slide move, but okay. Oh, yeah, that was someone else. That's me. Okay, so this is the benefit of using the PACS. And what I wanted to say is that any medication regimen that we put patients with dementia on should be evaluated according to the Beers criteria for safety. Again, I'm underscoring that more medication is not necessarily better, which brings me to the next slide that I would normally advance now. So this is the slide we're looking at now. We did another study of the PACS where we had two identical homes in 2013-14. And in one study, they used the PACS, in the other study, they didn't. And what we found is that although at the end of the study, there were no big differences in pain levels between the two homes, the PACS home and the care as usual home, we did see a significant reduction in benzodiazepine medications. These are anti-anxiety drugs that are often used in long-term care. And now I can't move the slide. No, not that one, back. Okay, so you could see in the PACS group at the beginning of the study, the average patient was receiving 0.22 benzodiazepines. At the end of the study, they were receiving 0.15. That's a drop in half. On the other hand, the control group doubled its medications from 0.22 at the beginning to 0.44. They exactly doubled the medications. So the pain assessment is not just a solution for reducing pain and improving pain treatment and pain care and getting the nurses to do a job that's not as stressful by managing pain patients better. But also, proper pain assessment can reduce polypharmacy. But for pain assessment to be done properly, it has to be done over time in this population. People often say, well, what is the cutoff score you can use? There is no cutoff score. There is no cutoff score because these are all different patients. Patients with dementia will, dementia is a very variable group of conditions. Some patients may have frontal dementia, may be very disinhibited, will show a lot of behaviors. Others will be more passive. Also, the type of the stimulus, the duration of observation, all these things affect the score of the PACS or any observational scale. In my view, it's a mistake to use a cutoff score. Instead, what you have to do is monitor patients over time and look when their scores go up and when their scores go down. And that's what we're seeing here. This is the example of a patient who was assessed daily over a month. And the red lines is the scores. We're not suggesting everyone should be assessed daily. We're suggesting that people should be assessed at least once a week for pain. But if you assess daily, what we're seeing here is an increase in scores, which reflected a leg injury of the patient, and here it reflected the flu. So this, as you can see, requires consistent attention to the patient. We know now how to assess pain. We developed guidelines. We published this paper. It's one of the most highly cited papers. In fact, it might be the most highly cited paper in the area of pain assessment in older adults. And you'd think that now everyone would jump and do what they're supposed to do according to these guidelines. But nobody's doing it. At that point, I had an existential crisis and began to question my career choices. I decided to ask people, why is it that nobody is doing pain assessments? And I'm trying to move a little bit quicker now so that I finish within about 5 minutes, and then Baba can take over. This is a mixed group of public policy experts and clinical pain experts from Canada and the United States who were asked the question, why is nobody assessing pain in long-term care the way the guidelines say? You can also see me here in the center at the age of 12. And the experts responded to this question by saying, the reason nobody is implementing your guidelines is because you've come up with the Rolls-Royce of pain assessment. Nobody can afford the Rolls-Royce of pain assessment. So you have to come up with something people can afford. So we then proposed a Prius, a Toyota Prius, a very simple way that we thought was very affordable for nursing homes to assess pain. Do one brief assessment a week on everyone. It takes less than 5 minutes. If there is pain, intervene within 24 hours, reassess after 24 hours, and then use this pain assessment information over time as part of your quality improvement plan to see if you're doing a good job caring, providing pain care for your group of patients. We thought that that would require a quarter of a nurse per 70 to 100 patients. We go to nursing homes with that. Now you guys can do this. They say, well, we don't have a quarter of a nurse. Tell us what to cut so that we can do your pain assessments. We also asked people in different provinces about the feasibility of the various recommendations that we made, the Prius recommendations, not the Rolls-Royce. And in a scale of 1 to 5, with 5 being good, everyone, no matter who we asked involved in long-term care, they said, we can do this, it's feasible, but then they're not doing it. So then, in desperation, I turned to engineers. Actually, the engineers came to me one time and they said, you know, we could do this. And I said, no, we can do what? Like vision system to measure pain? I started to laugh. But now, I know that that's a big part of the solution. So what we're developing here is a system to monitor pain behaviors in nonverbal patients with dementia in nursing homes without violating anyone's privacy. And that will not only allow for regular pain assessment, but for the possibility that we can do something that no human assessor can do, to monitor pain behaviors over time. We can do this 24 hours. So to accomplish that goal, we videotaped patients with and without dementia from multiple angles of observation. And that's not us, the guy with the hat there, that's just a stock photo. We're more professionally dressed, remember, somewhere between the tie and the pajamas, but better dressed than the guy with the camera. So, so we videotaped patients from multiple angles of observation because we wanted to see what the pain behaviors look like from different angles of observation. And then we coded those videos using the facial action coding system. That's the Lamboret system I described in the beginning, and the Paxlovid 2. That was 1,060,000 frames of video that we had to code by hand. And we did that. And that data is allowing us to answer questions besides the chronology development that we're not discussing today, but that's a very rich database. I want to show you here the people who actually did all the coding as a sign of compassion for them and appreciation. Odell Tan, Brooke Hoffman, and Erin Brown. The first two are now medical students, and Erin is finishing her PhD in psychology. So at this point, I'll pass it to Babak, who got that information from us, got all those codes, and used it to do the technical side of the development.
Thank you, Thomas. So while I wait to get control over the mouse and the presentation, I just want to say that contrary to what Thomas said at the beginning, I am in fact wearing a tie. Crystal, do I have control of the slides?
Yes, you do.
Okay. Okay, so as Thomas has been saying, nursing homes are understaffed and overworked. So they don't have the capacity to perform regular pain assessments. And he also talked about the Rolls-Royce and Prius models. Now what we're working on is Tesla or Uber of and automatic driving. The analogy with that is automatic driving. So we're working on automatic pain assessments. With the technology that we're developing, we're hoping to move away from this model that you can see in this slide, in which the clinician has to check on all the residents, to this model in which the artificial intelligence technology does an automatic pre-screening and automatically alerts the care staff if and when it detects signs of pain in one of the residents. What we're working towards is based on a proven computer vision technology using a technique called active appearance models, which you can see on the left. Active appearance models, or AAMs, are used to automatically place multiple landmarks, typically about 66 or 68 landmarks on key points on the face, and to track them over time. So this is what you can see on the left. What you see on the right is a sample frame from the UNBC McMaster shoulder pain dataset, which is the only publicly available dataset containing images of faces of a couple of dozens of individuals at various levels of pain, and also clinically valid assessments of pain on these image frames. This dataset was actually collected several years back by another member of our team, Professor Ken Prakachian, and another member of our team, Dr. Ahmed Ashraf, who's been a postdoc in our team, previously at a different institute, used machine learning techniques and showed that these landmarks on the left could be analyzed to automatically estimate the level of pain. So here's an example of using that technique to estimate levels of pain. So on the top left, you see short video segments. On the top right, you see the landmarks being tracked over time, and on the bottom you see estimates of levels of pain. So the analysis is based on the position of these landmarks at each image frame, as well as the appearance of the face, that is in regions in between the landmarks. The estimation of pain is frame by frame, so temporal information or how a person's expression change over time is not considered. So now with the data that Thomas and his team has collected in Regina, we've been working on trying to enhance this technology so it provides improved results on faces of older adults and older adults with Alzheimer's and dementia. And that's exactly where the data that has been collected by Thomas comes very handy, because artificial intelligence is all about training data. Artificial intelligence models learn from data, and the more data that we have, the better they perform. And as Thomas mentioned, we have over 1 million image frames, and for each image frame, we have a clinically valid assessment of pain, or in fact, we have multiple clinically valid assessments of pain. And the data is in the form of video, so we can use temporal information. And the other thing that we've been working on is to update these algorithms to take advantage of recent advances in computer vision and machine learning, and in particular using a technique called deep learning. These are deep learning methods are based on artificial neural networks with tens or even hundreds of layers of neurons, artificial neurons, And the recent advances in machine learning and availability of powerful computers has enabled the use of these very deep artificial neural networks. Deep learning techniques have actually become very powerful over the past couple of years, so they're very new. And now they pretty much beat every other technique in machine learning by a wide margin in a variety of tasks. So it's very natural to expect that we will also get very good results in detection of pain in older adults with dementia using deep learning techniques. And we have also a lot of training data, and deep learning is very hungry on using lots of data. So it's ideal platform for us because we have lots of data. In terms of the processing steps, I'm not going to go too deep, but this is just a very high level picture of what happens when we try to detect pain. The processing steps are 3. In the first step, we detect faces in an image. So for example, given an image like this, we need to say, here's a face. In this case, it's fairly easy because there's just one person in it. But if you have a camera that monitors the common room in a long-term care facility, then we need an actual algorithm that detects multiple faces in the scene. Then we need to track facial movements. So these are those landmarks that I mentioned before. And then finally, in the third step, processing step, we need to analyze this mesh that is placed on the face and the appearance of the face to assess pain. For the first processing steps, we actually didn't need to do much in terms of development. We've tested a variety of existing algorithms, and it turns out the face detection algorithms are quite good and mature. And here I'm comparing 3 of them. You can see true positive rates and false positive rates in blue and green. And if you look at the bottom row, you can see that one of the techniques that we tried, in fact, multiple of them, I'm just showing one as an example, has a fairly high true positive rates and fairly low false positive rates at different orientations of the face. So we're just going to use that without the need to do much change in those algorithms. For the second processing step, we've been doing a lot of work on the development and evaluation of various algorithms to detect facial landmarks. And we've tried various combinations of deep learning techniques and classical techniques. And I'm very happy and excited that the best results that we get are very, very accurate. And our success rate is over 97%. That means that the points that we place on the face, 97% of them are within a very small margin of where they should be exactly according to manual annotation. We've also done some work on transfer learning. In this particular project, we happen to have a really large amount of training data, but we've done some theoretical work for future projects where the amount of training data might be limited because it's very difficult to collect data from clinical populations. We've shown that we can, in future, for future projects, we can achieve good success rates even with the smaller training sets. I don't know if you can see all my panels at the bottom. I can only see 3 of them. The 4th one, for some reason, is cut. But what I'm showing is the leftmost panel. The left 3 are various benchmarks, and the one on the right, which is the best one, is what we can achieve. Oh, hello. For the pain detection, for the third processing step of pain detection, here I'm showing the results on the UNBC McMaster dataset. Using the appearance of the face alone, we get over 82% accuracy. So in 82% of the time, we can accurately detect if someone is in pain based on looking at their face. Using the mesh alone, we get a little bit more. And using a combination, we almost get 90%. So that's already quite accurate. 90% accuracy is fairly good. But in our ongoing work on the data collected by Thomas and his team, we expect much better results for two reasons. One is that we have a lot of training data, and the more, as I mentioned, artificial intelligence do better with more training data. So we're expecting upwards of 95% accuracy. We are also going to incorporate temporal information in our analysis, so that is also expected to improve the analysis and improve the results. In terms of commercialization and market size, the number of nursing homes in Canada is about roughly 2,000, and in the US is roughly 18,000. And there are about 1.7 million licensed beds in the US, and about a tenth of that in Canada. And a large proportion of long-term care residents live with dementia. So this is a technology that could be beneficial for a large number of people, and we hope that it can lead to improved quality of life for long-term care residents living with dementia, and it could also be helpful to the care staff by reducing their workload. And in terms of revenue model, we're thinking of installation at cost and a subscription fee, but the commercialization effort for this project is a work in progress, and we're moving towards it. So I'm gonna hand the rein back to Thomas, who is gonna finish off with those.
Yeah, I think, thanks, Babak, that was great. That's just one last slide, just to tell you what we're planning to do once we have the prototype ready for testing. In the first instance, we're doing two things. First, we're going to install the prototype, probably in a place like my lab, where there's a lot of graduate students going in there with the instruction to, when they go by the system, to do a pain phase, and just to see how well it detects and how well it picks up those things in the real world, in faked pain expressions before we go into a nursing home, so that we don't have to do all the technical installation troubleshooting in the nursing home. We're also interviewing a lot of stakeholders, and that's about to begin, hopefully in the next 4 to 5 months. Caregivers, nurses, but also relatives, patients who live in nursing homes, administrators, trying to find out what they think of that technology, whether they'd be likely to use it, adopt it, if they have any concerns, so that we can address those issues before we attempt to field test it. And then the field testing would take place in 2 nursing homes to start, and basically see how well the system works, whether patients who participate through the system, they get improved pain management, reduced pain levels, and whether nurses actually use the system. There will be a notification so that perhaps a light in the nursing station when the system detects pain, and then the nurse would log into the email to be informed of the patient number that corresponds to the pain detection. So that's what we're doing, and that's pretty much all. Do follow our labs on Twitter. I don't have control of the slides, so please move the next, somebody. Oh, maybe I can do that. No, I can't. Oh, I could. Oh, okay. Sorry. Anyway, follow us on Twitter. There's our web pages. And now, if there are any questions, we'd be happy to try and answer them. Thank you.
Thank you, Thomas and Babak. I don't see any questions at this moment, so maybe I'll start. I'm just wondering which cities, you may have said this already, but which cities are you testing this in so far?
So because we collected all of the clinical data in Regina, in exchange for the cooperation of the nursing homes that assisted us, we have agreed to have the first 2 testing sites in homes in Regina. And you know, once that's done, obviously we'd be more than open to move it across the country.
Great. And You mentioned something about caregivers. Are caregivers being kind of asked about how they would feel about their family member being monitored in this way? Is it something that gives folks kind of some peace of mind to know that there's kind of a system in place?
Yeah, and that was part of the implementation slide, that we will have focus groups where these types of questions would be asked. The most common concern that is raised when we discuss this is that what about privacy? What about video? It's important to underscore that there is no video recorded. We recorded video, of course, with permission as part of our data collection, but once the system is implemented, it will not be recording video. It would simply be processing the image, excuse me, for the purposes of analysis to determine if there's evidence of pain, but no video will be recorded. So there is no real privacy concern. It's as much of a privacy concern as it would be if you have a patient connected to a heart rate monitor or something like that. But yes,
Great.
we will definitely be asking caregivers those questions before implementation.
Great. So we have a question from Sarah. She's asking, would this type of technology reduce the need for higher proportions of highly skilled workers in long-term care?
That is the hope. That is the hope, because right now, nursing homes are saying they cannot afford the extra portion of a nursing position needed. We're hoping that that will eliminate the need to have a human assess everyone at least once a week. That way, when the system identifies pain, the staff can focus on simply assessing the individuals who show signs of pain rather than everyone across the board. So that's the hope, to reduce human resource demands. And actually, I would argue to even do a better job because of the possibility of continuous monitoring. I'll say I'm a psychologist, and in psychology, we use a lot of tests and quantitative methods for measuring different personality things. And as it turns out, what's most accurate is not the human clinical judgment, but it's those quantitatively developed tests. So in an ideal world, our system would even be more accurate and more precise than what a human assessor can do.
Great. Thank you. I don't see any more questions. So I just want to thank both of our presenters today and remind you that our next webinar is on February 22nd at 1 p.m. It will be talking about the application of an equity lens to the development of technology for older adults, and that'll be with Dr. Karen Kobayashi and Simon Carroll from the University of Victoria. So if you haven't already done so, feel free to register through the AgeWell website. And thank you all for joining us today. Have a great afternoon.
Thanks.
Thank you.
Thank you. Bye.